allow people to join. Welcome everyone, and thank you for joining us for another Building Better Business Practice Management webinar series. Tonight's topic is the importance of ICD-11, and we will be chatting with Galina Roofener. Welcome everyone for being here with us tonight. We're so excited to have you on. And for those of you that have not met me yet, my name is Natalia Morrison, and I am the Communications Director for FASOMA. And just like you, I'm also a licensed acupuncturist. So before we begin, I wanted to go over some housekeeping with you. So at the bottom of your screen, you'll notice a couple of icons. The first one is the chat icon. And that is where you can share links, stories, feedback with us. And if you want right now, just to make sure that you all know where it is, why don't you type in the city and state that you are in. So I am in Miami, Florida, and Galina is in Ohio, I believe.
Correct. Cleveland, Ohio.
Cleveland, Ohio. Good. So I see you guys have found the chat box. Hi, Ruth from Hawthorne. Kim from Orlando. Nice. Thank you. Thank you for joining us. We have someone from California, New York City. Wow, you guys are amazing. Thank you for being here and supporting us. Another one from Ohio, wonderful. Washington State. Oh, okay, I see, not California, Washington State. All right, so we're gonna leave the question and answer segment towards the end of our presentation, but it's open for you to submit your questions, and you're gonna be able to upvote your colleagues' questions, right? So that's gonna be another icon at the bottom of your screen. It says Q&A. So whenever you have a question about something that Galina is talking about, make sure that your question is as detailed as possible, because we're gonna hold the questions towards the end. And that way we know exactly how to answer and what you were referring to, what your question was specifically about. All right, so without further ado, Galina, welcome and thank you for being here with us tonight.
Natalia, thank you very much for invitation to all FASOMA. I am very, very thankful for an opportunity to speak about our importance of ICD-11. And if you will take a look at right corner upper side, I felt in love with that cartoon. So it talks about acceptance of ICD-10, which caused significant rise in human suffering by CMS officers. Now we are at ICD-11, and now we will feel the pain of that. So, but nevertheless, it is significantly to our benefit. It's one of the most important steps which our profession can take. And why it matters specifically for us as US practitioners. If we will take a look at current world population, we see that we are the third biggest country in the world. And what is very interesting, two countries which are bigger than us, China and India, and you see it right here, losing people every day. We gaining people every day. This is this year data. From the beginning of the year to today, it's almost 1 million people arrived to United States. So the number of patients is increasing for us exponentially, which poses a significant challenge. And let us do a money talk. Why? And there we stand as traditional Chinese medicine, comparing to China, for example. This is the latest data which I found. In 2006, in China was 166,614 TCM practitioners in hospitals and over 7,843 practitioners in private practice. It will be much higher numbers now. So all TCM practitioners in China at that moment were making 12% of all licensed doctors. If we will look in research in United States, we see that in 2015, in United States, we had just a little over 34,000 practitioners. Now I believe it's just a little over 35,000 practitioners. So it's not such a great growth in 5 years. And we comprise less than 4% of all United States physicians. According to China health statistics, there were 2,641 million visits to Chinese practitioners in 2017. On the contrary, in the United States, we had only about 10 million acupuncture visits. And if we look in comparison, visits to TCM practitioners in China composed over 32% of total visits to medical practitioners. And in United States, it was less than 1%. As a matter of fact, it was 0.113 below the decimals. So what it means, we have a tremendous growth potential. There is nearly not enough of us. We're not competitors to each other. People need us, they just cannot pay for us. And that is important. Does United States has money for us to pay for acupuncture? Yes, we do. We have the most expensive healthcare system in the world. And really not that successful at all. If we will take a look, and we are talking about Medicare paying for low back pain. Why they are paying for low back pain? Though sadly not to acupuncturists, but this is why. Total direct cost of spinal fusion surgery in United States in 2004 was $16 billion. This is unimaginable money. But the problem was that overall failure rate of that lumbar spine surgery was estimated to be anywhere between 10 to 46%. If I, as an acupuncturist, would be failing 46% of the time, I would be bankrupt. So it's why Medicare is so interested in acupuncture. Because if we can reduce the number of patients who are going for lumbar fusion surgeries, even 10%, we're saving for them an unimaginable amount of money, because otherwise we are bankrupting. That's why we are in such important stepping stone right now. And then we are speaking about Medicare. We always have that little illusion that, okay, Medicare pays pennies, so why I should bother? But in reality, it pays a pretty significant amount of money. Let's say in Cleveland Clinic, we charge $100 for a cash visit for acupuncture patient. Medicare pays just a little over $60. It's very comparable to what Medicaid pays. We accept Medicaid patients. And I have to tell you, We hired just very recently practitioner number 8, and we need probably another dozen to meet the demand, because every day number of patients is increasing tremendously. Another reason why it is important for us to be a legitimate members of healthcare community. If we look at safety of medicine, take a note. In 2019, we had 173,000 deaths from properly prescribed medications. Serious adverse events admitted to the hospital exceeded 1 million patients. If you look at Chinese herbs with all of the media paranoia, there are negligible numbers. And with acupuncture, how many deaths we had? 0 to none. We are a very safe procedure, even if we don't take into account our effectiveness. So now let us take a little bit more precisely, why specifically ICD-11, not necessarily just an acupuncture? Why we need to be able to bill for evaluation and management codes? First of all, this establishes traditional medicine systems as a legitimate part of healthcare. Until we have our own evaluation and management systems, we are a procedure. It's why, if you take a note, the same speaking about Medicare or Medicaid or many other governmental insurance, including TRICARE and so forth, they pay first of all for the acupuncture, which is a procedure. It's not a profession, it's a procedure. Our own evaluation and management codes allows us to be a separate system, so a separate licensed, independently diagnosing practitioner. Another benefit of ICD-11, specifically Chapter 26, it allows for setting of healthcare policy that recognizes traditional medicine as diagnosing provider. So then we finally decide and gather enough money to apply for inclusion into the Medicare. We can apply not only for acupuncture procedure, but also for evaluation and management codes, because we are diagnosing providers. Next important step, it introduces basis for integration of traditional medicine into operating and strategic planning and design of healthcare delivery systems. What that means, on many different levels, to avoid side effects, if we denote in electronic records Western medical billable diagnosis and traditional Chinese Chapter 26 non-billable diagnosis, and gather effectiveness and safety data, along with reduction of the visits of the patient to conventional medicine providers, we will have increase in allowed sessions of acupuncture. Because let us think about it. Why they decided that it's only 20 sessions of acupuncture which is allowed per year? Where are these numbers coming from? No matter how attentively I searched, I actually did not find any proper research supporting the dosage of acupuncture. That's where we come forward as an acupuncturist, and we need to establish number of sessions based on TCM pattern of presentation, because obviously, if it is just dampness impediment as exterior factor versus kidney yin deficiency with blood stasis and with zinc deficiency, it's a completely different number of sessions. That's where we come forward. Plus, it's very important to have a precise measure for quality, safety, and efficacy of care, especially about safety. Based on TCM pattern diagnosis, we can anticipate, will be there bleeding and bruising or not? Will our patient respond with dizziness or fatigue or not? What is, again, proper spacing between the sessions? Very commonly, especially for medical community, safety is one of the big important factors. And that in ICD-11, as a reportable diagnosis, allows for tracking of patient concerns and assessing the risk. Next important point, it's ICD-11 incorporation and acceptance, advances design of payment system and processing claims for reimbursement for TM evaluation and management codes. Yes, until we have our codes, remember, we are not diagnosing Western medical diagnosis because we, by definition, by our education, are entitled to put the Oriental medicine diagnosis. So here, right here is a clash. We have to have ICD-11 and we need to use it now. Dependent on the state, in some of the states, you may use evaluation and management codes, in some states not. Like, let's say in state of Ohio, it very clearly says that I'm not entitled to diagnose. It does not specify Eastern and Western, but if we have an ICD-11, that opens the door. As well, working in the hospital, majority of the hospitals do not bill for evaluation and management codes, even if they bill insurance, by a very simple reason, because we are not entitled to diagnose Western medical diagnosis. We can use symptom diagnosis, like low back pain is a symptom. Lumbar stenosis is a diagnosis, it's not a symptom. So we cannot bill for lumbar stenosis unless you have a written referral from your physician with established diagnosis. And still, as a primary billing code, you should put the code which insurance pays, supported by physician referral, and the second code will be your pain diagnosis because it's symptom and it is within your scope of practice. If you don't have a written referral from the physician, you should use a symptom diagnosis because that which is in our scope of practice according to our education. Because state law not necessarily read clear, and that's maybe a case for legal action. So be very careful with that. So another very important factor for accepting ICD-11, it contributes to prevention and detection of healthcare fraud and abuse. That's exactly the same question. If you want something have done right, do it yourself. Then we have evaluation and management codes based on pattern differentiation. Eventually, as a profession, we have to come together and establish the dosage of acupuncture for each pattern. And that's what we, as a practitioner on the big scale, can submit to insurance companies. As well, when we document in the progress and improvement of our patients, it doesn't mean that your patient have to be jumping around and be perfectly pain-free in 20 sessions like allocated for Medicare, but you have to document improvement. And after that, you might be entitled for pain management, which may be a different time frames. You don't have to use them all in 90 days. Because let's face it, acupuncture in very many cases is a functional approach. And if there is a big structural problem, pain will return. That's when we need to exercise the management option. So that's what will allow us to establish the number of diagnoses. And we need to do it now. Not when Medicare really accepts acupuncturists as a providers. Not when the United States adopts ICD-11. We need to speak in the same language way before and gather the research. If you think that nobody reads your notes, you're deeply, deeply mistaken. One of the big benefits of working for Cleveland Clinic, and I repeat, it's a benefit. For the last year and a half, due to us billing Medicaid, we are undergoing internal audit process. Every 3 months, auditor reviews 10 of my chart notes. And one of the things which they review, how well in my notes I supported the diagnosis which I billed for. Oh my God, how many times they made me cry. You even cannot imagine how many times they made me cry. So, but on my previous review, I had 100% passing rate. On this review, which I literally received just 3 days ago, I had 95%. And devil is in details. Like, let's say why I did not do 100. I billed for tension headache. I did all of the proper recording in the notes, but nowhere I mentioned that tension provokes the headaches. So auditor agreed with diagnosis of headache, but they did not agree with diagnosis of tension headache. So it's why it's very, very important for us to learn the mechanics, the little keywords, and it's all doable. You know, then you actually learn it, and then you start using electronic medical records software. And we use a template, and in my ICD-11 class, which I will be teaching on July 11th, I will be walking through all of those templates with exact details, how to. It takes less than 3 minutes to write appropriate template. To write appropriate note, just clicking in appropriate fields in the template. It's actually really, really nice. But another note about your SOAP notes. First of all, you always, as a practitioner, need to remember that you write in the SOAP note not for yourself. You're a last person whom we are concerned and we are reading SOAP note. First, you write in the SOAP note for insurance company to support why you billed. Did you bill for correct number of diagnoses? Did you meet all of the criteria for complexity? Did you notate all of the units of acupuncture, or did you notate the consult time which you spent with the patient? Did you document all of the improvement? And did you note the time and complexity of the note? Second person who is very important to please, then you write in a SOAP note, will be legal system. Yes, because if anything happens, any type of the adverse events, including bruising during acupuncture, or let's say diarrhea due to herbal formula, has to be reflected in your SOAP notes properly. If it's not written down, it did not happen. And the third person whom you are actually pleasing is your colleague, who will be providing continuation of the care. It's why this class on standard terminology and ICD incorporation came about. How I said, in my department, we have 8 acupuncturists, so it's multi-practitioner practice. We all were educated in different countries. We practice completely different styles of acupuncture, and we practice multiple styles of acupuncture during the same treatment. If I cannot understand why or what my colleague was treating, how we can do continuation of the care for the patient? Not happening, yes? And let's say in our practice, though we try to retain the patient with the same provider, but it's far not always happening. So accordingly, patients will choose to take the first available spot versus to wait 2 months for opening on my schedule. Accordingly, patient rotates among all of us. And then we are looking at documenting the progress and documenting the improvement. It has to be done at certain intervals. And usually standard practice among similar practitioners like us, like let's say chiropractors or physical therapists, do you reevaluate a patient condition every single time? Not necessarily. If I see patient 2 or 3 times a week, or even every week, how much changes? How much in that note I can write? Not that much. Can you completely duplicate the note? Absolutely not. Like let's say in Epic, your auditor can see exactly what you copied from the previous note. So you're writing essentially very little changes every single time. Has no sense to do that. And nor your physical therapist do complete reevaluation every single time, nor chiropractor do that. On average, accepted reevaluation schedule is about every 6 visits. Have you notated that if you went to your physician and they recommended for you some physical therapy before they consider further investigation like MRI or something like that, it will be minimum 6 sessions of physical therapy. And you know, in all honesty, I love number 6. In Chinese numerology, it means prosperity. Yeah? So let's designate number 6 session as our reevaluation session. In that, then you need to document the progress. If patient did not progress, why they did not progress, what were obstacles, what were contributing factors. So that is very, very, very important. And a lot of that is standardized language. That's where ICD-11 is important. So next point, why ICD-11? It facilitates research, epidemiologic studies, and clinical trials. We all know that if we use exactly the same points of acupuncture for, let's say, the same low back pain, it will be inconclusive. We need to have a pattern differentiation. Until it is here, until it is standard, until we have studies to support our conclusions, all will be inconclusive. So, and do you rely always on our official researchers? No, absolutely not necessarily. You as individual practitioner have all power in the universe to affect it. I would highly suggest for you to use electronic medical record systems. Why? Because that allows for data retrieval, easy data retrieval. Dependent on EHR system, like let's say right at the current moment, I provide some of the consulting advice for Crane Herbs in design of electronic healthcare system, which is very friendly for research, as herb research, as acupuncture research. And if we, as a practitioners, write our notes in standardized format with standard check-in points, with standard pain improvement evaluation, VA pain questionnaire is awesome on that subject. We can pull a really great research. And even if you are not interested in the research, we have plenty of students in doctorate programs who are suffering trying to find a material for the research. And they are reviewing inconclusive meta-analysis studies just on internet. Then we can help them. And it will be not only greenhouse studies, and it's exactly the same, just a traditional Chinese acupuncture points. Who said that there is sham acupuncture? By my opinion, there is no such thing as sham acupuncture, because there is Korean style, there is Japanese style, there is Sujok style, there is Toyohari, there is Worsley. We all work. So our big goal is to provide sufficient evidence about effectiveness of each style of acupuncture and defend our freedom of treatment. And ICD-11 in no means means that you are limited in what you do for the patient. No, it's only an option to write down what you did in standardized, retrievable way. But we don't want for us things happens like in China, then it's only these points and the rest doesn't matter and does not exist in the face of the earth. That is the great benefit of United States being an awesome melting pot. We accepted and we included every single style of acupuncture which exists today in the world, and we practice it actively. So there is no reason for us to allow for Western medical doctor who knows only TCM style to do research and dictate us what is valid and what is not. We need to use ICD-11 to express ourselves, but defend the freedom of the treatment. And we can do it. It's challenging, definitely challenging, but doable. So that's where we need to move a little bit forward. And let me illustrate to what I have been saying about difference. Let us take one case study. It's 30 years old male presenting with the chief complaint of pulling constant low back pain radiating to right buttock that started after camping trip 4 months ago to the lake, and it's worse with rainy weather. Severity of the pain is 4 out of 10. As well, he has a frequent dull frontal headache and sensation of heaviness in the body. Has a frequent loose stool as well. So current billable diagnosis, because it is a chief complaint, is low back pain with right side sciatica. If we look at different styles of acupuncture, we have different examinations, yes? How we find what is happening with the patient. We have different pulse language, and we have a very, very different TCM pattern or a traditional medicine pattern presentation. I cannot say that it's TCM because TCM stands for traditional Chinese medicine. And it's why ICD-11 is not TCM, it's TM, traditional medicine. And right now, ICD-11 published only traditional Chinese medicine, which is named TM1. But in the near future, there will be other traditional medicine systems published with standardized codes, as TM2 will be Ayurveda, TM3, I believe, will be Unani, and so forth. So it's why every single time then I use my ICD-11, I make sure that I put that this is TM1 pattern and this is a number. But if you look, each style essentially agreed on the cause, because spleen harbors dampness, yes, or creates dampness. CF, the same. Its meaning of the diagnosis, absolutely the same. Just language is different. That's what we will be talking about in my ICD-11 class or standard terminology on July 11th. How to convey the meaning of your diagnosis in standard language and still do not lose the spirit. It's very, very important for us to preserve our ability to practice the style of medicine which works in your hands the best. That was a pretty significant challenge for me, and I have been using ICD-11 for the last, year and a half routinely, especially for my herbal patients. And I have to say that for herbal patients, and in majority of the cases, herbal diagnosis is based on 8 principles, pattern differentiation. So it's fairly easy. With acupuncture, not so much. That then it's really pretty challenging to express ourselves in ICD-11 standard language. But how I said, we will be talking about that precisely because it's a long conversation with multiple examples and exactly how to write the note for each style, reflecting the necessary points to support your diagnosis and still be compliant with billing requirements. So here's the website, which is available. And let's move that. I'm not sure, can you see it or not, but right here is the website address. That is ICD-11. And if in previous times, all of the ICDs from number 1 to number 10 were paid and you needed to pay to use them, ICD-11 is completely free. It's available on the website, and World Health Organization encourages you to take a virtual tour and gain hands-on experience. It is available starting from acceptance at World Health Assembly on May 25, 2019. How soon it will be really adopted and accepted in the United States, who knows? We usually are behind. With my last conversation with Marilyn Allen, I believe that Korea started already accepting and adopting ICD-11. So obviously we will be a little bit behind, but nobody forbids us to use ICD-11 standard terminology today. You cannot bill with ICD-11, doesn't matter today or in the future after acceptance. It's still chapter 1 through 24. Even with acceptance of ICD-11 will be billable diagnosis. This is your Western medicine chapters 1 through 24. They will be billable. ICD-11, the entire purpose is for statistics. In that there again, our conversation about importance of dosage of acupuncture, about effectiveness of acupuncture. If you think that they will not gather that statistics, oh yeah, they will. Like let's say, I will provide for you a lot of original source links. I just very recently was looking at VA, since VA is the first government organization which employed acupuncturists, and listening to Julie Olson, she is a lead acupuncturist for VA, about a week ago. They had a few dozen practitioners now employed by VA. So when you write in your notes, you always will be reflecting billable diagnosis and non-billable ICD-11 diagnosis in comments window. That then it's still retrievable for research purposes, but it's not billable. It's not necessary goes to insurance on your HCFA form in any means. This goes in your notes, and especially explaining why patient is progressing and improving, how they are improving. In the future, then ICD-11 is accepted, that then we will be instructed how to reflect our ICD-11 codes on insurance forms, but not today. And just don't be illusioned. In my big class, ICD-11, we will be talking about standard terminology, how to reflect your preferred style of treatment in standard terminology. It's not an insurance billing class in any means. If you are puzzled how to bill insurance, please take Mori West class on July 18th, which will be held through SOMA. It's awesome class. I recommend for everyone. And in general, you see how much potential we have because we as a providers are reimbursed for seeing patient face-to-face. We are not paid for herbal formula compounding. We are not paid for time which we spent on billing services and so forth. We paid for seeing patient. So let us be professional. Let us support our organizations, FASOMA, ASA, NCCOM, and make sure that we are enrolling or applying for acceptance as a providers to Medicare, because this is our ticket to the bright future. If you think a little bit, you as an individual provider are not obligated to accept Medicare patients whatsoever. If you don't want to, you don't have to. As a matter of fact, you are not obligated to accept any insurance whatsoever. But do you want to accept insurance? Yes, you do. In Cleveland Clinic, about 90% of my patients are insurance patients. In my private practice, probably a good chunk of patients are insurance patients as well. And then I was practicing in Florida, about 70% of my patients were insurance patients. Right now it's a little bit less because I focus a lot on herbal medicine. So, and herbal medicine is not paid well by insurance. So, and again, it's because of evaluation and management codes, because your herbal medicine is not a procedure like an acupuncture. All of it is consult. And as well, if we adopt and accept ICD-11, we have our evaluation and management codes. You use one diagnosis for acupuncture and you use completely different diagnosis for your Chinese herbs. I would highly suggest for you, separate your acupuncture appointments from your herbal appointments, because the amount of time which we spend with the patient should be supported by your notes as well. And we will be talking about with clear examples on how to support everything what you did with your notes. But that will be your opportunity to get double pay, because you see patients for completely different diagnoses. There is absolutely no need to squeeze everything in one visit. Rather space it out, share responsibility. With us being able to bill insurance and see more patients, you don't have time to spend on filling up of HCFA form. Outsource the billing. There is plenty of insurance companies, AcuClaims, Holistic Billing Services, Sam Collins, whichever state you are at, whichever insurance company specializes in billing for acupuncturists and specializes in your state is an awesome source, and they usually will monitor any changes very quickly and they will guide you. It's exactly like auditors in Cleveland Clinic. I am so thankful for my tiers because they made me really much better practitioners and made me to understand no one else except the hospital internal auditor will come back to you and explain why your claim has been denied, how you need to correct your notes. So that's the experience which I will be sharing with you in my class. That's few things which I would like for you to tell. And I guess that would be it about my talk today. So I'm ready for questions. Natalia, back to you.
Wonderful. Thank you, Galina. So if you'd like, you can turn on your video so our viewers can see you. And that was amazing. Thank you so much. We're already getting feedback of appreciation from people that are watching. And this is your time, guys. Take advantage. If you have any insurance questions whatsoever, please ask them now. Kimberly says, thank you. Great presentation, Galina. So there's a question that came in. It says, please clarify insurance coding date and SOAP note date. Also, will this be available as a video? Yes, so this is being recorded. For those of you that have to hop on or hopped on late, you'll be able to rewatch this later on over and over because there's a lot of really good, useful information on this presentation. So the question, Galina, is please clarify insurance coding date and SOAP note date.
So the big webinar, which I will be talking about, will be teaching about, it will be on July 11th from 11 a.m. to 7 p.m. Eastern time. And this is approved for 22 PDA through NCCOM and 21 CU through Florida. And because this class is actually a fundraiser, I will donate 50% of my proceeds to Florida State and ASA NCCOM to support our efforts to become a Medicare providers. So your money is not coming just to my pocket, it's to support expenses and to support our profession. It will include 7 hours of face-to-face time via webinar, and it also includes additional 14 hours of independent studies, because we do have a standard terminology manual, which we will review with the most important terminology in the class, and remaining manual you will be looking at home, and it's 327 pages. So it's not like all the CEUs are just free and given for nothing. There will be also a lot of practice using ICD-11 website and writing the SOAP note. As one of the provisions in the class, I would require from each of you as a 10th question on the quiz to write a SOAP note based on provided SOAP note template and submit it to me. And I will come back to you and offer for you suggestions how to correct your SOAP notes.
Oh, wonderful. That's great.
Paid for sure.
Yeah.
But again, it's not the billing, it's coding. It's exactly which language you use and what you write in the SOAP note.
So then the SOAP note date versus the date would be like the date of service and the date that you write your SOAP notes.
No, then you write in your example of SOAP note for me, it's just imaginary date, and it's based on your real patient from your practice.
Okay. Okay.
We want to make it real. Yes, it's all about practical skill. It's very little theory. It's more about practical skill, how you use it, how you do it. And we want to adapt your SOAP note to your preferred style of acupuncture, not just classic TCM points. If you practice Worsley style, let's write the SOAP note in Worsley style. If you practice Toyohari, let us write it in Toyohari style. I use a Japanese style, Manaka style in particular. I do a lot of scalp acupuncture. I do a lot of Korean style Sujok acupuncture. So it's quite challenging to reflect it all in the notes. And again, it's not only just about for you getting paid. It's a little bit more. It's about future of the profession. I was breaking my head how to make the SOAP note easy, quick, but how we can collect the information for research purposes to support the future of our profession. For it would be not acupuncture versus sham acupuncture. No, let us differentiate what is TCM style of acupuncture versus Toyohari style of acupuncture versus usual care.
Yeah.
That's what is our goal. As well, then we are collecting the improvement of the patient. We need to know what was the success in this particular pattern. Some of you might remember, and if you are SOMA members, return to autumn edition of SOMA journal. or you can get on my website, asiantherapist.org. In a blog section, you will find an article, Dosage of Acupuncture, that I presented for case studies, all of them on low back pain with different pattern diagnosis. And let us take a look what is percentage of improvement we are expecting in 6 or 12 sessions. That's what is important. That's what insurance companies want from us. And we'll need to look at real practice, not just those which are designed by Napadov in Harvard. Let us be real. Let us do clinical. Let us do pragmatic. How much money we save for our healthcare. And another thing which we always need to think about, so we as Oriental medicine practitioners don't give a Hippocrates oath, but this is our direct duty to help our patients.
Mm-hmm.
And that's where our research comes forward, our good soap note writing, our usage of standard terminology, supporting our statements for patients would have access to us. Even if you don't want to take Medicare, if you don't want to have insurance, to take insurance, doesn't matter. Profession at large needs to be. Yeah. We need to be present in every hospital.
Thank you for saying that. Yes, I think it's important for all of us. The future of our profession.
Absolutely. So, and even if we have to wear a mask today and space our patients, like we run in Cleveland Clinic at 50% capacity, allowing for our patients to be sure that all of the rooms are disinfected, that we are spacing them out, that we are providing all means of safety, since majority of our patients are older. Yeah. Not that many of 30 years olds come to us, but that's actually another benefit of ICD-11 and thinking about how we write our notes, how we separate acupuncture appointment from herbal appointment. Because that's what allows me to practice telemedicine and practice my herbal appointments and still be able to bill for herbal appointment without violating the rule that I cannot bill reassessment codes more frequently than once a month.
Yeah. And you know, it's something that isn't really talked about.
Yep.
There's a lot of, you know, I've been in practice for 10 years and we were taught, or I was taught, that it was the amount of time that I was with a patient practicing or doing acupuncture on that patient. But we do herbal consultations and wellness consultations and, you know, our office visits. We can separate it and charge it like that. Not everyone that comes in, I do acupuncture on or cupping.
Absolutely.
And not
on everyone you do your herbs whatsoever.
Right.
So another thing, and that's another very important point, which I will be talking about in my class, and majority of the notes actually will be targeting not necessarily 2020 billing rules. We will be talking about changes which Medicare puts on our EM codes for 2021. It's completely different set of rules now.
Wow.
Completely different requirements. So first of all, in 2021, Medicare will pay exactly the same amount of money for your evaluation and management codes level 1 through 3. It's only level 4 which will have the different amount of money. So it's doesn't require from us any longer blown out of the proportion notes. But your note must to support what you do.
Right.
In very concise manner. So that's one of the points which we will be talking about. Another thing which will be very important in 2021, we can start utilizing billing based on time spent. But that's how you specifically write it in your notes. It's not any longer meeting the specific criteria, because for us to meet level 4 notes is almost unrealistic, not happening. And if you're trying to do, they will deny you. And even if they approve you, after the audit is done, they will come back to you and say, oh, we overpaid you. Now you owe us money because you did not support at the level of EM code what you bill. So next year, they actually will be paying for time not only spent on face-to-face, but they also will be paying for pre and post-visit paperwork, for you reviewing the records of the patients, for you maybe placing your herbal formula, or maybe even somewhat compounding the herbal formula.
That's
So that's
great.
exactly we will be going through in the notes, how you write your notes for the future. Because this year is almost gone. I'm not concerned about this year any longer, you know? And with all this COVID, we anyway screw it up and we see half of the patients what we see. But 2021, because the paradigm of our healthcare industry shifts, we no longer pay just for blown out of proportion and medical note. Now we are switching to outcome-based model. And our medical decision making, which we reflect in assessment portion of the notes, that would becomes the primary importance. Your treatment plan, what you wrote in your treatment plan. And now all of your consulting for the patient, that's what actually allows for you to get paid more.
And that sounds wonderful.
Absolutely.
Yes.
Absolutely. And with templates, it's 5 minutes, you're done. Especially for the follow-up. For the first time, yes, it involves the work. It's why they start paying more. Because it does involve. You need to spend time on reviewing records, on reviewing tests, and especially first time in Florida is an excellent state. I am feeling like I'm in a restraining jacket in Ohio.
Yeah.
Literally how limited my scope of practice is. But in Florida, every single test what you order it for a patient, doesn't matter, do you use scope and order just a conventional medical test? Do you use ZRT lab and you order your salivary profile? Do you use Genova and you order all of your stool tests and everything else? Every single thing, now you can actually reflect and get paid for that in 2021. And you know, it starts with Medicare. It probably will take for a little while for private companies to accept it, but year or two, and that will be it. They all will be on exactly the same page. And in your acupuncture note, what is your outcome? Did patient improved or not? How it's improved? And it's not only percentage of pain reduction, they want meaningful improvement. Is it range of motion improved? Is the patient capable to walk instead of 15 minutes, 2 hours in Costco now? That is a big achievement. So yeah, that's what they want to hear now.
So we definitely have a bright future ahead of us in regards to how insurance is shifting and allowing us to grow as a profession.
Absolutely. And you know what is very interesting, because we already use these templates, we already incorporated it, and because patient is essentially an owner of their information, yes, by HIPAA Act. In Epic, they can see my notes. And I cannot tell you how many patients I had coming to me with my printed notes and saying, oh, I so love your plan of treatment for me.
That's wonderful.
Absolutely. Absolutely. Because that's where we are at.
Yeah.
And every single recommendation for your patient, that proves your qualification as a practitioner. You know, I always remember Dr. Ia. He has been my teacher at East West College in Sarasota, which I graduated from. And one of the phrases which struck me, which he said, the qualification of the physician reflects in his notes. And that is true. I see a lot of snowbirds, yes? Ohioans love Florida, let's face it.
Yeah,
It's nice and warm in the winter.
it is
And
really.
I asked them all, bring the notes back from the practitioner what they saw in Florida. It's why I will provide for you a template.
Yeah. One question just came in.
Mm-hmm.
So do we need more codes for billing? Do we have codes for herbs?
Herbs are just like a drug in Western medicine. We always bill for consult. It does not matter what remedy we prescribed, be it herbs, nutraceutical, homeopathics, or whatever it is. We are paid for face-to-face with the patient. Today, in 2021, we can be paid for face-to-face and consult for the patient, education for the patient. We are not paid for herbs per se. Herbs, unfortunately, remain as OTC drugs, and accordingly, patient may get reimbursed based on your notes. Like I have quite a few patients who come to me for herbal appointment, and because I outsource herbal compounding to Crane Herbs, it is in their medical record, it's considered to be as OTC prescribed. Accordingly, their flexible spending account sometimes may reimburse it. Will it change or not? It depends, but we always bill for consult, EM, evaluation and management code, if it is within your scope of practice in the state that you are licensed.
Perfect, thank you.
So an acupuncture is a procedure. It is billed in addition to evaluation and management codes. And also there is a little caveats. Like let's say, if you spend in half an hour on consult with the patient, this is your consult time. But you cannot bill consult time for acupuncture every single time. If you don't do extensive reevaluation and physical exam, you can't. Because normally within acupuncture codes, procedural CPT acupuncture codes, there is some time billed, like if I'm not mistaken, it's 6 minutes per unit, what you spend on greeting the patient, on bringing patient into the room, obtaining patient immediate changes, brief history, washing your hands, and writing the notes.
You're only allotted 6 minutes to do all that.
It's what is billed in our acupuncture codes, yes? 6 minutes per unit. And unit is 15 minutes, yes?
Mm-hmm. Yeah.
So.
We all have a lot to learn, and we are lucky to be able to have you, that you're doing this fundraising webinar on July 11th, and 50% of the proceeds are going to FASOMA and to, you said, the NCCOM?
NCCOM, ASA, American Society of Acupuncturists. So literally to support our efforts to bring acupuncturists as a providers for Medicare.
Thank you. And that's really generous of you, because I know that you have so much knowledge to give, and I've taken some of your webinars and they're so detailed. I mean, you definitely invest a lot of love and time into it. And so we're all just very lucky to be a part of it. And
appreciate
it. Yeah, thank you. And like you mentioned, Maury West, she's also doing a 2-day webinar, the 18th and 19th of July, and we're hosting it through FASOMA as well. Absolutely. And if you remember,
my webinar is not a substitute for her webinar. I'm not talking about, you know, the insurance biller side in any means. I'm speaking only about quality of the notes, which needs to be in the note to support what you're billing for. But how to bill, that's Maury. I outsource my billing to the professional. I don't do it myself.
Yes, and I
It
think
takes cost too
both
much.
are important. Yeah,
Absolutely.
both are very important. And from the time that I've been in this profession, the more that you can learn from different professionals and experts, the more empowered you are. So thank you for everything that you do for our profession, and thank you for sharing your time with us and doing this free webinar for us. It really means a lot. Thank you.
Appreciate an opportunity. Thank you so much for everyone who attended.
Thank you. And thank you everyone who joined us, and we will see you next time.
Bye-bye.
Bye everyone.